This animation summarizes the most important surgical steps of the SYNFLATE vertebral augmentation system. This animation alone does not provide sufficient background for direct use of the instrument set. For a more comprehensive understanding of the surgical technique, please refer to the SYNFLATE Technique Guide. One inflation system is required for each SYNFLATE balloon needed in the procedure, and all inflation systems need to be prepared at the start of the procedure. Using a bowl, prepare a mixture of 2 parts saline solution, 1 part contrast medium, and allow 15 milliliters for each inflation system. Place the end of the tubing into the bowl of liquid and hold the body of the inflation system in one hand. The dial of the inflation system should be placed downwards and the white T-handle upwards. Push the white wings down towards the dial. Using the other hand, slowly pull the white T-handle upwards to draw the liquid up into the fluid chamber. Once the chamber is full, release the wings. Take the tube out of the bowl and tip the inflation system so that the handle is pointing downwards. Tip the fluid chamber to drive any air bubbles to the top. Rotate the T-handle clockwise to expel all the air bubbles and keep turning until the red mark on the plunger reaches 0. This particular animation shows the transpedicular approach, using a guide wire first to create a path for the trocar. However, if the surgeon prefers, a single-step approach using just the trocar can be taken. Use biplanar fluoroscopy to introduce the guide wire at the required level. Then carefully introduce the working sleeve and cannulated trocar over the guide wire, again using fluoroscopy to ensure that the guide wire and trocar are not advanced too far anteriorly. The end of the working sleeve should sit approximately 3 mm into the vertebral body. Once the sleeve and trocar are positioned correctly, remove the guide wires, followed by the trocar, but leave the working sleeve in situ. This working sleeve is now the access for the drill and the plunger, the balloon, and the bone filler in the next few steps. A channel now needs to be created for the insertion of the balloon into the vertebral body. This can be done directly with a plunger, or optionally, a drill can be used first. Take the hand-operated drill and carefully insert through the working sleeve, taking care not to overdrive the tip into vascular structures beyond the anterior wall of the vertebral body. For safety, this should be conducted using fluoroscopy. The first distal etching on the shaft of the drill indicates when the tip leaves the working sleeve. The next 3 etchings indicate the size of the balloon required, i.e. small, medium, or large. Once a channel has been formed, use the plunger to determine the appropriate balloon size. The plunger may be advanced by hand or gently hammering on the blue handle. The plunger has 3 grooves towards the distal tip that correspond with the 3 initial lengths of the SYNFLATE balloons, again small, medium, and large. In this case, 2 grooves are visible under lateral fluoroscopy, allowing for a maximum balloon size of medium. Once the vertebra has been prepared, attention can turn to the preparation of the balloon catheter. Remove the SYNFLATE catheter from the packaging and tightly engage the stiffening wire into the proximal luer end. The stiffening wire helps the catheter keep its shape and rigidity during insertion through the working sleeve and into the vertebral body. Remove the red cap from the side arm of the outer luer and tightly attach the vacuum syringe. Draw back the syringe plunger to its maximum extent and lock in place by turning clockwise a quarter turn. Then remove the syringe from the luer arm. Remove the white cover sleeve, but don't dispose of it, as it can be reused later for folding back the balloon should the catheter be needed again in the same procedure. Insert the SYNFLATE catheter into the vertebral body through the working sleeve. Note at this stage the white band along the shaft of the SYNFLATE catheter. This corresponds to the initial length of the chosen balloon. The balloon is clear of the working sleeve when the proximal end of the white marking of the catheter shaft disappears into the working sleeve. Check the balloon position by identifying the markers of the balloon under fluoroscopy. Connect the inflation system to the side port of the catheter. Inflating the balloon can now begin by turning the white T-handle on the inflation system slowly in a clockwise direction. This should be done with fluoroscopic imaging, stopping every few seconds to allow the bone to adjust to the pressure and volume changes. Inflation should stop when the following occurs. The desired outcome is reached, the pressure reaches 30 atm, the maximum fill volume for the balloon is reached, or any part of the balloon length touches cortical bone. To deflate the balloon, slowly release the pressure by turning the T-handle in an anti-clockwise direction until the pressure reduces to approximately 10 atm. Slide the wings of the inflation device forward and pull back on the T-handle to draw out the liquid and create a vacuum. Release the wings to seal the vacuum. The whole catheter can now be withdrawn, taking care not to disturb the working sleeve. Take the injection needles with the clips out of the packaging. Move the clip to the starting marker to align the distal tip of the injection needle with the distal end of the working sleeve after insertion. Slide the injection needle into the working sleeve using fluoroscopic imaging to check for safe positioning. Connect the clip of the injection needle to the top of the working sleeve. Advance the injection needle to the anterior part of the vertebral body. Connect a bone filler delivery system to each luer lock of the injection needle. Slowly, and using fluoroscopic imaging, monitor the fill pattern of the cement carefully, checking for any indication of leakage. Once the appropriate volume of bone filler is injected, disconnect the syringes, carefully remove the injection needles, followed by the working sleeves, while paying careful attention to the waiting time recommended in the instructions of use for the bone filler. The wound should then be closed and the patient treated thereafter as appropriate by the surgeon.